And we're off. It is in fact Tuesday, March 11th. Oh my God, 2025. We're starting the Public Safety Subcommittee, and this is here in 174 for those who are tuning in. Well, if you know where you're at or you wouldn't be there. Okay. Meeting's called to order. Excused are Representative Helfrich and Senator David Brock Smith, although we may make David Brock Smith wear a tail or something later just to make us happy, but they're both excused right now. We're going to turn to Steve and tell us what we're doing for today before we open up the meeting.
Good morning, co-chairs, members of the committee. Today we continue hearing House Bill 5004, the primary budget bill for the Department of Corrections. Just a reminder that the materials for DOC's presentations this whole week are posted on OLS under yesterday's meeting, Monday, March 10th. Thank you, Mr. Co-chair.
All right. We need to do any business before we open up the information hearing? All right, good. Open up the information hearing as a continuation. As sand goes through the hourglass or radar turns, please come on back up. House Bill 5004, Department of Corrections. Impress us. Sans dogs.
Chair Evans, Co-Chair Broadman, members of the committee, my name is Mike Reese. I'm the Director of the Department of Corrections. We'll pick up where we left off yesterday. Assistant Director Josh Highberger is going through our operations section. And once he's completed, then Deputy Director Steward will come up. We'll talk about health services. And then Larry Bennett, our Assistant Director, will come up and finish the day for us. And I'll turn it over to Josh.
All right, thank you. All right, good morning, Co-Chair Evans, Co-Chair Broadman, and members of the committee. For the record again, I am Josh Highberger, Assistant Director of Operations for the Oregon Department of Corrections. Yesterday, I had the opportunity to provide an overview of the Operations Division, highlight our 12 institutions, discuss the Operations Division's budget, and provide an overview of our 3,311 employees that are part of our division. We left off looking at the breakdown of our 2,240 security positions statewide. And as you heard from Director Reese yesterday, these security positions are some of the hardest to recruit and retain. Here on the graph that's shown here are the vacancies by facilities to include the overall number of vacancies after the bar graph. Currently, we have 248 statewide vacancies in the security series, with 200 of those being correctional officer positions. I would like to highlight the 5 orange facilities on the graph, as they represent 84% of our current security vacancies across the state. We know that staffing vacancies has negative effects on our staff and the AIC population at these facilities. Correctional staff have very demanding roles where a work-life balance is critical to their personal health. We're a 24/7 operation and have essential posts that must be filled to safely operate. And staffing vacancies increases the need for both voluntary and mandatory overtime. These vacancies also impact operations and the adults in custody, as institutions must modify their operations and close down non-essential posts to help minimize mandatory overtime. Closing down non-essential posts can result in less AIC access to recreation, activities, and at times other communications. And although we have made gains at several of our facilities, as you see on the graph, there's also still much needed work at those targeted facilities.
Co-Chair?
Yes.
Could you go back, sorry, Josh, one slide?
Yeah.
Can you talk about, I mean, I'm not asking for a description of every single element that's leading to this, but can you compare, for instance, Eastern Oregon to Snake River and why you're seeing such a, Eastern Oregon being one of the highest percentages and Snake River being one of the lowest? Like, what are the different causes of that?
Yeah, in some ways, the work is, Co-Chair Broadman, members of the committee. Yes, once overtime increases at a certain facility, that puts added work on the employees that are there, so it's mandatory. So in some ways, that continues that morale, and that hurts as well. But other known factors are also Eastern Oregon and Two Rivers. Some of the key things we know is just housing, available housing in those areas. We also know cost of living adjustments. It's a much different price to find housing, say in Wilsonville, than some of our outskirt facilities. Other known factors are competing businesses in those areas. Mm-hmm. We know that some look very competitively of our wages, so they know how to compete. And also in our local areas here in Wilsonville, they're surrounded by 5 local counties that also a lot of our staff go to work for those as well.
Okay, thank you.
Any other questions while we're here? Proceed.
Thank you. The department has recently taken additional action to address our staffing shortages at those facilities. We have recently hired a human resource assistant position at Coffee Creek Correctional Facility and are adding 2 additional positions to support the hiring process at our other institutions with the highest vacancy rates. Additionally, we have created a correctional specialist trainee position at Coffee Creek, Two Rivers, and Eastern Oregon, which you heard Director Reese mention yesterday. The temporary correctional specialist trainee positions were introduced in December of 2024, with 22 individuals hired into this classification thus far. Currently, 17 employees are filling these positions or in the process of becoming permanent correctional officers. And to answer a question that was presented yesterday, we have seen 4 of those 22 being released or have dropped out thus far. The graph here,
If I could just, while we're here. So I understand the new training approach. You're working with DPSST on this, correct? I'm seeing nods, so you're good. So just as a long-term request, the closer we can get the training so that people who are trained for counties and state can, over the course of their career, switch back and forth if they want to be able to keep folks in the career field and professionalize it, is something we hope we continue to work towards. So just mark her down, keep going, it's all good.
Noted. Thank you, Co-Chair Evans. The graph that you see here shows the number of individuals hired as a correctional officer or correctional specialist trainee at Coffee Creek, Eastern Oregon, and Two Rivers correctional institutions 3 months prior to implementing these strategies, so the September to November date, and the 3 months since, the December to February date. Now, although it's still early in the process, we are seeing positive gains. Despite our current staffing levels at several institutions, please know incredible work continues to take place every day within all of our institutions. One area where we've made notable strides is in the services we've been able to offer to our higher risk population. These are the adults in custody who are often the most challenging to manage and who have the greatest need for support in addressing their criminal behavior and their disciplinary conduct. We have been able to develop the role of Assistant Superintendent of Special Housing. This role will be crucial to the success of our special housing initiatives, with focuses on reducing staff assaults, increasing out-of-cell time, consistent practices throughout the state, and identifying key deliverables and outcomes for data collection. In addition to the Assistant Sup of Special Housing, we have recently established several housing program coordinator positions statewide. These coordinators will deliver evidence-based programs to adults in custody assigned to the disciplinary segregation units in our medium institutions, and our intensive management unit at Snake River, and our behavioral health unit at the Oregon State Penitentiary.
So before we move on, another question. Yeah. Since a former governor, if not illegally, then certainly without legislative approval or assistance, did away with death row, how is the behavior of those happy people compared to other folks? Are they all ending up in the high-risk population, or because some timed out and were older, they're not a problem? Interesting, people want to know how that worked out.
Yeah, Co-Chair Evans, I don't have all that information available to you at this time, but we will. I know an incredible amount of work went into when we dismantled that unit to find that appropriate housing. I do know some went into our general populations, our administrative housing, and some into our intensive management units, but we can find that information for you. Thank you.
Thank you. Any other question? See?
Thank you. Next slide. In addition to our evidence-based programming and special housing, we are also making progress with our Oregon Away initiatives and our specialty teams connected to this work. We're allocating resources to support and implement the following specialty teams. The first is contact mentors. A contact mentor is a correctional officer or staff member assigned to a small group of adults in custody to help support their success and address potential issues before they arise. The top left photo is some of our Powder River contact mentor team, who have hosted and trained multiple different states based on their success. The next is activity teams. The activity team is a mobile unit that operates throughout the institution, focusing on individuals who are self-isolating or other high-risk individuals requiring additional support to stay on track and avoid restrictive housing. Our first mobile activity team is currently located at Coffee Creek Correctional Facility in Wilsonville, which you see some of that work being represented in the top right photo. Next is our resource teams. Our resource teams are in our special housing units and are designated to train and empower staff to work safely and effectively with the highest risk, highest needs adults in our custody. The goal is to reduce the number of significant incidents and use of force incidents, while significantly increasing the AIC's time spent out of cell, and ultimately help the individuals live safely and successfully without restrictive housing. We currently have a resource team at the Oregon State Penitentiary and at Snake River Correctional Institution, which you see here represented in both the bottom left and right hand photos. We're also actively working to develop the first resource team unit located at Snake River Correctional Institution. The purpose of the resource team unit is to create a supportive and structured housing environment for adults in custody who are considered high risk. The overall goal of the unit is to provide a pathway for AICs to transition from isolation to a more normalized living environment, where the ultimate objective of helping them reintegrate successfully into the general population and the community upon release from custody. We are very proud of these volunteer teams, of the work they have done, and we look forward to the opportunity to expand them. And finally, this morning, I would like to review and enhance the security efforts we hope to implement. Yesterday, Director Reese discussed the enhanced security measures we have begun to implement around drug detection and wastewater testing, canine drug detection, and updates to our mail rule. While we ask for your continued support in these services, we also share with you the enhanced security effort we hope to implement in the future. The first here is body scanners. Searches are a crucial part of ensuring the safety and security of individuals in custody. They help prevent the introduction of contraband, such as drugs, weapons, and other dangerous items. Both closed and unclosed searches can be traumatic for both AICs and staff. With the support of GIPA Policy Option Package 201, we will be able to install 5 body scanners at Coffee Creek Correctional Facility, which will help minimize the risk of trauma and re-victimization, while also enhancing the security of the institution. Looking ahead, we plan to make a trauma and safety-informed approach and introduce additional body scanners at other facilities across the state if the opportunity is provided.
I gotta ask, because we've been having a study that's ongoing between body scanners and dogs, and all kidding aside about the dogs. Are we convinced this technology is as good as the dogs at this point, or are we trying to do both at all these institutions? I don't really want to just rely on technology.
Co-Chair Evans, no, thank you for the question. I believe a holistic approach is the best approach. That includes any access to safety and security equipment, including dogs, helps that. Body scanners definitely helps the introduction, coming in from the public or at intake or outside crews. While also those drugs, along with wastewater testing, includes our targeted searches in those areas to look at what might be in the institution.
Good.
Thank you, Co-Chair Evans. I guess more a comment to the general conversation here with canines. Being a former canine handler in the Air Force, explosive detection was my priority, and your dog team is only as good as the training that they get, and continue that. Technology's there, but I think, as they said, the reliance on technology and the canine is a good thing. But I'll take a dog any day over the week in detection work, because I believe their nose knows as long as they're doing their job.
And what I'm trying to get at is, I know that the folks that tell you about budgets say dogs may not be the best investment over time, whatever. But having both at all the institutions that we have concerns about, instead of just relying on one at any one institution, I think is probably going to get you more support from the body and also probably better results. Just my thoughts. Go ahead.
No. Co-Chair Evans, no, thank you. We have seen a dramatic effect of those dogs. We appreciate it. I, as a prior superintendent, have well utilized those animals for our targeted searches. It sets a precedence within our institutions, and we appreciate that support.
Okay.
Next, we have drone detection. Drone-based contraband delivery is an escalating threat worldwide, with technology advancing rapidly. These systems allow for real-time detection and tracking of potential drone activity within the secure perimeter of our facilities, helping prevent escapes by gathering intelligence on facility layouts and security patrols, and safeguards both staff and adults in custody by intercepting contraband and weapons before they can be smuggled into our institutions. The next is body-worn cameras.
Do you have the legal authority to do what you need to do to prevent them from actually, like, detection is one thing, there it goes. Do you have the authority to take them out or EMP them or something if they're around?
Chair Evans, it's my understanding that we are prevented from intercepting drones by FCC regulation at this point in time. It is controlled by the federal government, and our ability to detect drones with this technology is there, but to intercept them and bring them down would be out of our legal jurisdiction at this point. It's our understanding.
I'd like to follow up with that when we can. Thank you.
Thank you.
No one's left. Yeah, seems-
Any
Go
other
ahead.
questions? Thank you. Body-worn cameras. Body-worn cameras are essential for recording interactions between staff and individuals in custody. They provide valuable evidence in case of incidents and complaints and enhance accountability, discourage inappropriate behavior, and foster transparency within the facility. We have recently been in touch with the vendors that provide body-worn cameras to the Oregon State Police and who have successfully implemented body-worn cameras for the Florida Department of Corrections and the New York State Department of Correction. Florida reports seeing a 70% decrease in excessive force complaints and a 42% reduction in staff assaults, while New York has reported a 52% drop in Prison Rape Elimination Act complaints. Implementing body-worn cameras would not only improve the safety for both staff and individuals in custody, but we suspect would also lead to cost savings in litigation due to fewer allegations and contribute to better staff wellness with fewer assaults. And finally, electronic mail. While recent revisions to our mail rule have been implemented to address concerns regarding safety, security, and well-being of both adults in custody and staff, states that have implemented electronic mail have seen a complete elimination of contraband in AIC mail, reduced mailroom grievances by up to 95%, increased processing times by up to 80%, and enhanced security and intel, all while enhancing the ability for the AICs and their families to communicate more frequently through the use of individually assigned tablets. And with that, I would like to thank you for the opportunity to speak with you all over the last 2 days. We take great pride in the ongoing work of the Oregon Department of Corrections. And while acknowledging there still is important work ahead, our focus remains on staffing initiatives, staff wellness, expanding resources for our AICs and the high-risk population, and prioritizing future security measures to enhance the safety and well-being of both our staff and the adults in custody and our care in custody. Thank you.
Thank you.
Co-Chair.
Yes, sir. Go ahead.
Thank you. This has been really informative. Are we gonna, because I don't want to waste time now if we're gonna touch on it later, are we gonna talk about some of the trends in terms of interception of contraband or the assault issue or staff assault issue, or should we wait on that information later?
I don't believe, yeah, Co-Chair Broadman, I don't believe that's coming, but I'm happy to get any of that additional detail.
I don't want to create a lot of additional work. I'm
No,
really
please.
focused on workplace safety and staff assault trends and what
Yes.
we're seeing over, the last years plus, if we're seeing things trending in a particular direction in terms of staff safety. I know it's high priority for you. I just want to see the data. And then the other thing would be, if you have data about interception of contraband that's coming in that, when you started doing wastewater detection, did you see trends? I'm also curious if there's wastewater detection related to things besides drugs like COVID and public health issues. I don't know if you're doing that testing. Those are again, I don't want to take too much time, but those affect the budget, and I'd like to know more about it.
Chair Evans and Co-Chair Broadman, we have the data for you. The testing is still in a pilot phase. We're still new with the testing at the 3 facilities. We are testing for other things besides the contraband drugs coming into the system, so we'll have that information for you. And we are seeing trends around the testing we're doing with drugs coming into our system. So, for example, we had intelligence that indicated a group of individuals may be bringing methamphetamine into our system. They were placed in disciplinary housing for another matter, and we saw a drop in methamphetamine in the wastewater testing while they were in segregated housing. So those are the types of confirming intelligence that we're hoping to get from wastewater testing.
That's great. A follow-up, Co-Chair. Good. Yeah, I mean, that's exactly what I'm looking for is, an investment in a body scanner is showing a drop-off in the wastewater positive results.
Thank you.
Thank you, Co-Chair. Which facilities is the wastewater testing pilot happening at?
I'm Chair Evans and Co-Chair Broadman, Representative Choatson. We're doing it at OSP, OSCI, and is it Snake River?
I believe Snake River, yes.
Okay, thank you.
And I'll invite Deputy Director Steward up.
Thank you.
Good morning.
Welcome.
Thank you.
Good to see you.
Good morning. I am Heidi Steward. I'm the Deputy Director for the Department of Corrections, but I'm also serving as the Interim Health Services Assistant Director, and that's what I'll be talking to you about today is what's going on in healthcare. I've been the acting Assistant Director since the end of November, and that's given me opportunity to really work closely with our healthcare professionals to identify the things that are working and the things that aren't working. And there's certainly a lot of challenges that we have been facing as of late, and I'm going to touch on some of those today and give you some updates on where we're at with those things. But I also want to highlight there's a lot of good work happening in our institutions as well in healthcare. There are a lot of innovative ideas and passionate people. And so I want to have the opportunity to highlight some of the good work that's happening in the institutions in healthcare. I'll cover these topics. I'm going to fly through a few of these slides pretty quickly just to get us caught up on time. And then that way I have the time to spend on the really important matters. I'm going to cover these topics throughout the presentation. This slide highlights the health services budget in comparison to the DOC total budget. This slide reflects our current 25-27 budget by section. Medical services utilizes a managed care model to provide medically necessary care to those in our custody. This means we have on-site primary care, coordinated care and management of disease, controlled access to specialists and specialist procedures, a pharmacy medication formula, and a claims review. So this is very similar to what most people would receive in the community with their primary care providers. AICs can access care by verbally asking for it or in writing. We have 5 facilities statewide that house AICs with an infirmary level of care. Another small 8-bed infirmary is slated to come on this year at the Deer Ridge Correctional Facility. Health Services provides care aligned with nationally recognized evidence-based guidelines for individuals with chronic diseases and other significant health conditions. Individualized treatment plans are developed with goals to decrease the frequency and severity of the symptoms, to prevent the progression of the condition, and to minimize complications. Anything outside the scope that our on-site providers can do, we send outside to outside providers and contractors. Some telehealth is used for specialty care services to reduce off-site care, and I'll spend more time discussing off-site care because that certainly has been one area that's been challenging for us over the last at least a year. Behavioral Health Services, BHS, provides services to patients with mental illness in 10 of our 12 institutions. We do not provide services at the South Fork Correctional Facility or the Warner Creek Correctional Facility simply because of resources. We work with our patients to help them understand their mental health diagnosis and offer opportunities for learning practical skills to help them manage with their medication, with their symptoms, activities of daily living, and how to communicate well with their providers. Care is prioritized to patients who have severe and persistent mental illness and other high-risk factors. The BHS team is comprised of approximately 200 staff, in addition to contractors that represent the spectrum of mental health professionals, from psychiatrists and psychologists to qualified mental health professionals and qualified mental health associates. The team provides a continuity of services from initial intake assessments to transition plans for reentry back into the community. Services are evidence-based. Our substance use disorder treatment is also part of our behavioral health team. Substance use disorder impacts those in our care at a higher rate than individuals in the community. So 64% of those in our care report having a substance use disorder, and 50% of all AICs are classified as having a severe need for treatment. This is more than 4 times higher than the national estimates of community prevalence, which is approximately 15%. We offer a variety of programs to address substance use disorders. Our primary service are milieu-based programs, which provide a minimum of 6 months of intensive group and individual treatment. These programs are trauma-informed, gender-responsive, and utilize evidence-based curricula. Additionally, our BHS team provides a program of 9 to 12 months of intensive treatment in a mental health special housing unit for individuals with co-occurring disorders. Yes.
So I have to ask the perennial chicken and egg thing here.
Yes, sir.
Are we putting our chips down on when they first come in or before they leave? Getting them into the treatment.
Getting them into treatment. So I was just jumping in to treatment is also available in outpatient, so we do both. So we assess them when they come in. Our outpatient treatment programs are actually new. We got funding last biennium to bring those online. And then our residential 6-ish month treatment programs are at the tail end. So we're trying to get it at all areas, trying to provide treatment at all stages of incarceration.
Okay.
Okay.
Thank you.
Yes. So treatment is also available through outpatient treatment programs at 4 of our institutions. These outpatient treatment programs utilize a chronic disease approach to care, which allow AICs to receive individualized treatment designed to meet their assessed needs. These programs utilize certified AIC peer recovery mentors, and these mentors can lead groups and they can meet with individuals one-on-one. We are currently recruiting for 3 of these programs and making progress in our recruitment efforts. Our programs also provide relapse prevention planning and care coordination for those releasing to the community. Dentistry. Most of our AICs prior to incarceration have not received timely and appropriate preventative dental care. We provide comprehensive services to those in our care that include items on this slide and more. DOC dentists pride themselves on their ability to perform some of the most complicated surgical procedures in-house. For all the procedures that they can't do, we do send individuals outside to outside specialists. We operate 2 pharmacies and 2 medical supply warehouses, one set in Ontario and the other set in Salem. These entities supply pharmaceuticals, durable medical equipment, supplies, and equipment to our patients and clinics. Pharmacy operations prepares, packages, and distributes over 46,000 prescriptions per month, averaging well over 500,000 per year. Pharmacy stores purchase, stock, dispense, and maintain various supplies, instruments, equipment, and devices needed to provide care to AICs. Examples include wheelchairs, CPAP devices, infirmary beds, bandages, gloves, and syringes. DOC Health Services is facing significant challenges, with some of the biggest challenges listed here on this slide. So Josh and his team are facing staffing challenges, and we are as well in health services. We have seen some recent successes in filling hard-to-fill positions, such as medical doctors, but we continue to experience difficulties in filling vacancies with permanent providers. We are in final stages of hiring a recruiter who has experience in healthcare recruitment. This recruiter will be dedicated to health services, so I'm hoping once that recruiter is on board that we're really going to start to make some progress in this area in recruitment.
Okay.
Yes, sir.
One of the, not sure you could actually label this as an opportunity, but
Okay.
given changes and things that you're looking at and the struggle for staffing,
Yeah.
when some of the folks from a couple of your institutions came in and talked to me, they were talking about, and again, this is a small issue, but the time and the trouble it takes to get outside medical crews, ambulances, et cetera, in and out. Mm-hmm. Is there an opportunity for perhaps the different facilities to have their own EMT and transport service in-house to take pressure off the community? Because I assume the procedure to get in, get the patient, and get out,
Yeah.
it can be a challenge. And if that's keeping somebody on the outside from getting care because of limitations and budgets, maybe this might be an opportunity to make your system more efficient. I don't know. Seemed reasonable to me. If you could look at it, that'd be great.
Co-Chair Evans.
Oh, I have a different question, so I'll follow up in a sec, yeah.
Okay, I'll look into it. That's the first that I've heard, that it is causing such an issue. So we'll certainly discuss it, and we'll see what we can do to minimize that risk, certainly.
Sounds great.
Yeah.
Thank you, Co-Chair. I guess I'll add a comment and then a question. I just have to say, with the Coffee Creek facility, which I serve as a firefighter and paramedic, we don't have that issue. It's necessary security, but they're right on it. We're in, we grab patients, we're out. But my question actually is about Coffee Creek. What is the current status of women's health, the inpatient women's health care there? I know that's been struggling for a while, and just kind of wondering what you have to update us on that.
Absolutely. Co-chairs and Representative Graber, I appreciate the question. There has been a lot of challenge at the Coffee Creek Correctional Facility. I'm going to talk about it in just a little bit. We're
great.
changing
Thanks.
structure there, and changing the management structure there. So we're adding an assistant medical administrator, which will be assigned to Coffee Creek and Columbia River, will be housed on site at Coffee Creek. So that's where their office will be. Right now we have 2 assistant administrators, and they are split between east side and west side of the state. And we're also bringing on a nurse manager. So we'll have a nurse manager over our minimum, a nurse manager over our medium, and a nurse manager over our intake process, which we don't have right now as well.
Good.
Follow up, if I may. Thank you. Is the nurse manager involved in direct patient care as well?
The nurse manager can provide some direct patient care, but usually that is our registered nurses that provide direct patient care.
Okay. Yeah, I think I just want to flag, if it's okay, like the need for that direct patient care to increase. So
Yes.
thank you.
Co-chairs, Representative Graber, absolutely. We are doing a lot of work in that area as well. Also in communicating with the women there. One of the biggest challenges that we found is that oftentimes it's a lack of communication. They don't know when their appointments are scheduled. They don't get a lot of follow-up afterwards. So we're working on putting together town halls with our medical providers to answer their questions, general questions, and then we have computers available to answer individualized questions as well. So working on that too. So lots of things happening, and it's Coffee Creek's at the top of our list.
Thank you very
Yeah,
much.
thank you. We will continue working with staffing agencies to fill vacant positions. These include adding physician associate positions to increase the applicant pool, as well as working with our third-party administrator, Correctional Health Partners, to identify specialists to potentially provide on-site care or telehealth services. Talked about right-sizing management structure here just a minute ago. We are right-sizing our management structure at Coffee Creek. We are additionally right-sizing our management structure at OSCI and SCI as well, to better support staff and the needs of those institutions. Off-site care. Increasing availability for off-site care, and it's listed on this slide, I believe, as, out-of-facility scheduling. This is at the top of my list. It's at the top of my priority list in figuring out how to reduce or mitigate the barriers that are in place right now. So we are behind in scheduling specialty care with outside providers. To fix this, I've restructured the scheduling team. So all schedulers now report to one supervisor. They did not before. Their supervisor is a clinician, and she is working on identifying and addressing the bottlenecks in our system. With adjustments that we've made to date, we are seeing progress. In January, our offsite medical trips were 14% higher than the 2024 year average. We expect continued progress in this area as we bring on additional staff to help with the workload. Additional wheelchair vans have been ordered, which will increase capacity for our transport team to get patients to their appointments. CQI, so this is continuous quality improvement. We do not have a formal CQI program in healthcare in the Department of Corrections. And CQI is a best practice in healthcare to examine strengths and weaknesses of a healthcare delivery system. It's shown to improve patient outcomes while supporting cost avoidance by identifying inefficiencies, reducing waste, minimizing risk, and avoiding adverse outcomes. It requires a clinical administrator to manage the statewide CQI program, which includes regularly scheduled audits, process and outcome studies, ensuring compliance with policies and procedures, and developing performance improvement plans when deficiencies are identified. So we are working with the Falcon team. I believe the director mentioned the Falcon team yesterday. We have contracted with them to look at our healthcare delivery system and to make recommendations on ways that we can improve. Also highlight what's working well and put a report together so that we can start working towards improving the healthcare system. So the Falcon team is helping us find position descriptions from other states that do this work well and helping us with a structure that could work here in our healthcare system around a CQI program. Medication for opioid use disorder, MOUD, has been problematic since we moved away from using injectables. While there were a number of reasons why we moved to using a tablet, this change has increased our medlines significantly. In a lot of institutions, our medline times have doubled. Some AICs, in fact, even skip medline because they don't want to wait in line, so they aren't taking medications they really need. The tablets are also much easier to divert, so we're seeing a lot of diversion of the pills. So the current MOUD program is straining our security and healthcare resources as well, and it doesn't provide optimal care to AICs. So we're redesigning our MOUD program for optimal care and to better utilize our staffing resources.
So just
Yes.
in layman's talk, you're going back to give shots?
Yeah, we're looking at going back to the injectables, once a month injectable.
Good.
Yeah.
Okay.
Thank
Thank
you.
you.
We break medical acuity into 5 categories. MH5 are the most acute. This table shows the percentage of AICs in each category. I will say today, not every AIC has an acuity score, but when we implement our EHR, and I'll touch on the EHR in a little bit, that will change. It'll be required that every provider put an acuity score in all of our AICs. So this data will actually be better next time we see you and present to you. There are many factors that determine acuity level, like type and number of illness, care needs, age, cancer remission years, average number of contacts with health services per month, and so on. As the age of our patients increase, so does their acuity. When acuity increases, more encounters are required with our clinicians. With age comes mobility issues, cognitive impairments, and multiple chronic diseases. When this happens, general population is no longer a place that these individuals can live. In these cases, we typically use infirmary beds, even though these individuals are not on acute status or are post-op patients. Sometimes we even use mental health housing unit beds. I was at the Two Rivers Infirmary actually last week, and there were 12 patients in the infirmary. Only one was there for acute care. The rest of the 11 were there for long-term memory care type issues. We have limitations to facility infrastructure as well. 4 of our facilities do not have healthcare on the first level of the facility. For example, the infirmary at the Oregon State Penitentiary is located on the 3rd floor. As you know, it is a very old facility, and so a lot of times the elevator to get to that 3rd floor doesn't work. Cell doors in some facilities are not wide enough for wheelchairs or walkers to pass through, and AICs may need to navigate a steep ramp to get to the shower area. Cell structures are often not conducive to many assistive devices or ADA modifications. All of this to say, it is difficult to meet the needs of our acute patients with some of the prisons that we have in place today. This next slide details mental health need. MH3s reflect our highest need clients. As examples, schizophrenia and bipolar disorder fall into this category. So MH3 clients generally receive the most frequent and intense level of services from our behavioral health team. MH2 represents clients with a diagnosis such as borderline personality disorder and post-traumatic stress disorder. Clients in this category are still managing a pretty significant mental illness. Clients designated as serious mental illness, we always refer to them as SMI, are a subset of the MH3s and MH2s. So having an MSI designation indicates an individual's mental illness and associated symptoms are having a significant negative impact on their ability to function in their daily lives. Approximately 8% of our AIC population has an MSI designation.
Excuse me.
MSI, SMI designation, yes.
So one of the things that I'm still trying to grapple with in terms of psychology is the rating is how the disease or how the chemicals, whatever it is affecting the person. Is there also a ranking or a determination of how, because of that activity going on with that individual, the threat that they have on others?
We don't necessarily rank that based on their mental illness. So we have,
But their behaviors.
we do assess people for risk of behavioral issues. But it's not in combination with their mental health illness. So they have a mental health rating, and then we determine level of risk.
Okay. Offline, I'd like to learn more about how you determine that.
Yeah, absolutely. We'll follow up with some documentation on the different ways we assess people.
Okay.
Yeah.
Thanks.
Yep, absolutely. Okay, MHRs represent clients with a diagnosis such as adjustment disorder and ADHD who can manage their mental illness with the help of psychiatric medications. So they see a prescriber, but they don't require individualized case management. And then MH1s are very similar to our MHRs. They have adjustment disorder and ADHD. However, they can maintain stability without psychiatric medications and behavioral health interventions. So pandemic-related disruptions continue to impact our system. Mental health acuity is increasing. So comparing today to pre-pandemic numbers, we've seen a 20% increase for women and a 30% increase for men with a mental health diagnosis. As a result, our higher level mental health treatment beds are full, requiring clients to wait on mental health housing until a bed becomes available. The largest budget drivers for health services are variable. They're clinical staff, off-site care, and medication expenses. Our variable costs are impacted by the number of AICs in our custody, but are also heavily influenced by a variety of other factors such as age, medical, dental, and mental health conditions. Here are some details around some of these, around the three of these budget drivers. When we have vacancies in clinical staff, such as nurses, physicians, psychiatrists, and nurse practitioners, we of course pay overtime and utilize contract staff to ensure the care is provided. These solutions, of course, come with a cost. So to
Excuse me.
Yes,
Go ahead.
So can you go back one slide? I'm sorry.
absolutely.
So, and if you're going to touch on this, just tell me and ignore the question. But I recall from prior biennia the issue with the number of people with Hep C. Is that stabilized, gotten worse, or gotten better?
Still an issue. And I actually believe that the cost for Hep C medications are going to go up this biennium. And I'll tell you why in just a second when I talk about, I'm going to touch on that just a bit.
Thank
Yep.
you.
Let's see. So to provide an example, this slide shows total cost to the agency for both DOC RNs and contracted staff. These numbers do not reflect what an RN makes, but it is, again, total cost to the agency. So if a DOC nurse is at top step, it's $93 per hour total cost as compared to $165 for a contracted nurse. As noted on the right, we spend about $17 we spent about $17.4 million last biennium on medical contracting services. We are projected to spend $33.2 million this biennium on medical contracts, which is a 52% increase. There are two main reasons for this. Our need for contracted nurses due to difficulties in recruiting RNs. Although we do have some great contracted nurses, they are averaging a 34-week assignment. So we don't see the same skill level as we do with a well-trained permanent nurse that we have on staff. So it takes more contracted nurses to actually do the same work that a trained RN does that is a permanent employee. Another reason for the higher numbers is we started using a second locums contractor 2/3 of the way into the last biennium. So you see an increase in contracts with bringing providers in to fill the vacancies. Question?
I have a question. So am I reading this right, Director, that could basically, I mean, if you paid more for your top DOC RNs, you would actually save money if you were retaining people because you wouldn't have to do the contracts?
You're reading that correctly.
Okay, thank you.
Off-site care. So this slide shows the top 5 off-site care diagnoses based on cost. As I mentioned, we utilize a third-party administrator, the Correctional Health Partners, for our off-site care and hospital coordination and billing. Our third-party administrator provides a discounted provider network and comprehensive case management to reduce hospital bed days and improve clinical outcomes. Medication expenses. Pharmaceutical costs continue to have a significant impact on expenses. Hep C, antivirals remain at the highest cost medications the department purchases, but there are other medications that drive pharmaceutical costs as well. Long-acting injectable antipsychotics are being used more commonly in general practice and communities as well as in our institutions. They are normally reserved for those patients that have difficulties with taking their medication, possibly due to anxiety, mental acuity, and severe psychosis. Biologics are a relatively new type of medication and are now widely used to treat autoimmune disorders. HIV remains a treatable healthcare condition that the department does aggressively treat. Anti-neoplastic medications are used to treat various types of cancers. These 5 specific types of disease states and the medications used to treat them represent roughly half the pharmaceutical expenses and are used to treat only 7.5% of our AIC population.
So, sorry, back up. The neoplastics?
No, all of these on this list. All of these on this list represent half of our pharmaceutical expenses
And 7% of the people.
and 7.5% of our AICs. So our high-need AICs are driving this budget.
Okay.
I suspect next biennium, this list will change a little bit, and we'll see the addition of medication for opioid use disorder on this list, along with an increase in expense for hepatitis as we bring on clinical pharmacists. I'm going to talk about clinical pharmacists here in just a minute. So improvements in health services. While we're experiencing our share of challenges, we also have seen improvements in our healthcare delivery system, ranging from technology improvements to added programs, services, and resources. I'll highlight a few of these areas, some of which have been implemented fully, while others are in the process of being implemented. Our therapeutic levels of care committee. Some people may be surprised to see this on our list of improvements, but truly it is. We have spent a lot of time, I should say Dr. Seal has spent a lot of time, and his providers have spent a lot of time really looking at that process. So the process and meeting cancellations were creating delays in getting patients scheduled for off-site care. These problems have been fixed. A list of clinical issues no longer go through therapeutics level of care committee. We are trusting our providers to use their independent judgment and make appropriate referrals. Additionally, meetings are no longer canceled, so if the chair can't make it, someone will fill in, and those meetings will always take place so that there's no backlog in this review process. Our doula program It's a great program. I'm not going to spend a lot of time talking about it. I think you all are familiar with that, but we are really happy to have it at the Coffee Creek Correctional Facility. We talked about the SUD pilots. So these substance use disorder pilots are at OSP and SRCI. They are running, and AICs, they are running, and we're providing treatment. We're still hiring for some of the positions, but we're well on our way. Clinical manager is now supervises master level interns completing their degrees in social work and counseling. So we believe this intern program will greatly assist us in recruiting behavioral health professionals. We have a collaboration with the Oregon Health Authority on 2 projects to provide resources to AICs releasing from DOC. OHA Justice Involved Navigators will assist AICs to connect to MOUD services in the community. In addition, OHA has provided grant funding to DOC for a transition professional.
Excuse
who-
me?
Yes.
Oh, I was going to wait for her to stop talking.
No, you're
you
good.
can finish. I'll follow up at the end of the slide. Yeah.
Okay.
Sorry.
OHA has provided grant funding for professional who will assist AICs living with HIV to connect them to housing and other resources upon release. Do you want to ask your question? Or
Yes,
Okay.
thank you, Co-Chair. Just backing up to the substance use disorder, is
Yes.
there, I think you may have, I just want to just still drill down a little bit. So when you have AICs at intake who are suffering from opioid addiction, are you able to route them directly into like Suboxone treatment?
Co-chairs and Rep. Graber, yes.
Okay.
Yes. So if somebody comes to us from the community and they're on MOUD, we will continue them on MOUD treatment. And then if they're not on MOUD and they need it, a doctor will evaluate them and determine what's appropriate.
And that happens in that initial window. Great, thank you.
EMDR. So in 2024, BHS offered eye movement desensitization reprocessing, EMDR, training to all licensed master's level clinicians. EMDR is an evidence-based therapy for individuals with a history of trauma. This treatment isn't appropriate for everybody, and there's a lot of skill building that has to take place ahead of this. But it is a program we're proud to have on board now. Cognitive behavioral therapy for pain management. Together, BHS and medical provide cognitive behavioral therapy for pain management. Medications can only do so much for chronic pain. And so this program teaches skills to help manage the impact of pain and what it has on someone's daily life. 340B drug pricing, we've collaborated.
Thank you, Co-Chair. I'm just curious to know, because you mentioned that the EMDR isn't for everybody. I'm just curious to know how many folks are utilizing that?
Co-chairs, Representative
Or receiving
Campos.
those services?
I don't have those numbers with me today, but we will get that to you and put it in a response.
Thank you.
Okay, yeah, absolutely. So 340B drug pricing, the program offers the department some of the lowest cost pharmaceuticals through federally administered contracts. All cost avoidance from this program must be reinvested in patients through expanded care and services. We have purchased DOSIS and Pyxis machines to better distribute, secure, and administer medications. DOSIS devices are automated blister packaging machines that speed the process for preparing medications for distribution. And Pyxis machines are automated dispensing cabinets, so they're best described as like an ATM for pharmaceuticals. They are secure and accurate in dispensing medications at the point of administration, helping our nursing staff to better document medications given and allow our controlled substances to be monitored much more closely. Both machines can integrate with the electronic health records, allowing for increased workflows, ease of administration, and decrease error potential.
So I'm going to regret asking this, and you're probably going to regret me asking it.
No.
Given the super effective cybersecurity network that the state of Oregon has, an ATM that dispenses drugs that I assume is tied somehow into a network, how's that going? And how do we know it's secure?
So, co-chair, It's not, I will get you more information on how it's secured and tied. There is a nurse there. It's not like someone can go right up to the machine and pull out medication. So we have a nurse RN there as they're pulling their medications out of the machines.
Somebody could theoretically hack it, so she may not know that she's pulling out things
I
for
don't
people.
believe so, but you are asking questions that are now outside my level of expertise. So I will talk to our pharmacy administrator who will have all those answers for us.
Thank you.
It's secure.
It's, yeah, I know it's secure. I just can't explain it to you. So I'll get that to you.
If everybody who told me things were secure were right,
I know. Pyxis is secure.
all right, go ahead.
Yeah, we'll get you information. Clinical pharmacists. We recently piloted using a clinical pharmacist to deliver a collaborative drug therapy program. The pharmacist helps expand the bandwidth of our practitioners by seeing patients diagnosed with hepatitis C and treating them. The process involves utilizing evidence-based practices to help treat and educate patients while carefully monitoring patient outcomes. We plan to add additional clinical pharmacists to further expand the capacity of the department's healthcare providers, help treat and educate our patients, and improve patient outcomes. And so that's where I see some of the Hep C drug usage going up as we spend time on this. It's going to, we're probably going to utilize more of the medications. Dental was comprised of one chief dentist and one manager to oversee the entire dental department. We've restructured, we've put more managers in place to help oversee that because we operate 15 different dental clinics across the state. It was becoming too much for those two individuals. EHR. DOC is close to implementing an electronic health record system. Configuration nears completion along with interfaces with various systems, conversion of paper records to digital, creation of training material, infrastructure work, and more. We have planned a multi-phase rollout to our 12 institutions, starting first with a pilot at the Coffee Creek Correctional Facility for females in August, followed by the pilot at OSP in September, and then the remaining institutions in November. Originally, we had hoped to have full implementation by the end of this biennium. It was an aggressive timeline, and in the end, we determined it best to push this out just a few months. There are several reasons for this. Key functions weren't ready for user acceptance testing. A trainer had resigned. We had a new assistant director take over as the sponsor of the project. We had a change in our chief of medicine. Performance speed issues were identified, and more time was needed to develop, train the trainer, and super user training. The delay is not indicative, Representative Evans, of a potential project failure. We will have an EHR. Some of the issues for the delay have already been resolved. There is one component, however, that will not be fully functioning upon implementation, and that is the dental component. The requirements for medical and dental vary vastly, so we'll focus on dental once medical is up and fully functioning. We will have dental partially up, so we'll be able to use we'll be able to utilize chart notes and that sort of thing. We are not requesting any additional funding for the implementation delay.
So just a comment that I know you know is coming.
Yes, sir.
In 15 years or 11 years, between Oracle and I don't know how many case management systems at OPDC and SOS and DMV not communicating and a number of other high technology things, you see the concern on many of our faces anytime Oregon is going to implement a new system. So
Yes.
for the love of God, please get this one right so we can celebrate it. We can't have another failure right now.
Co-chair,
Evans, we
We-
will not fail.
we will not fail. And I will say we want it in place more than anybody. The amount of data that we're going to be able to pull from this system, the amount of time it's going to save our providers, even in litigation when we can't read handwriting or it, and on so many levels, we are desperate for an electronic health records. And like I said, nobody wants it more than us. And we will celebrate sometime this year for a fully implemented EHR.
Okay.
I saved EHR for the last part of my presentation. So that concludes my presentation, but I'm happy to take any questions.
Representative of them.
Thank you, Co-Chair. Since the themes of the day have been staffing and then health services, kind of putting those two together, in terms of the offsite visits, could you just speak at all to what the staffing needs of an offsite visit are? I imagine it'd be because you have transport and security and all that goes into that. I imagine it's a little bit complex. And then I also just still from yesterday, I'm thinking about what a fraction of the offsite visits we have this past year that we had a few years ago. I know staffing needs, are those two connected at all? Could you speak a little bit more to that, please?
Yeah, absolutely. Co-chairs, representative, happy to speak on that. So yes, we are going to need additional staffing to help take care of this problem. Right now, we have really focused on identifying where the problems are, creating systems that will help mitigate those problems, and identifying what staffing resources we need. So we have about 5 schedulers across the state assigned to different institutions, and their needs are different. So for example, on the west side of the state right now, we're in the process of hiring 2 more, excuse me, 2 more schedulers. We may need to also hire some transport staff, but we need to figure out first if by bringing on those 2 schedulers, can the community meet the demand in appointments that we're scheduling, right? And then on the east side of the state, I believe at Snake River, the problem is we need to expand the slots that our transport staff can accommodate. So we're bringing on a couple more transport staff on the east side of the state. We'll continue to evaluate the rest of the state where we identify the problems and determine where the needs are. So the needs vary depending on what institution we're talking about.
Quick follow-up.
Of course.
And backwards looking, has lack of staffing been a barrier to getting people offsite care when they might have needed offsite care, but that staffing wasn't available to transport them?
Co-chair, representative, I think it's a combination. I think that it has been a system problem that we've had to fix, and it has been staffing resources. What I don't know at this point is how many permanent staffing we need. So we're bringing these positions on to really get through the backlog, and then we'll determine, okay, what do we need to keep from getting in that spot again?
Thank you.
Yeah, you're welcome.
Yep. Thank you, Co-Chair. So I'd like to get some additional information on this aging population, like maybe how many are currently incarcerated that are over the age of 65? What are they incarcerated for? How much time do they have remaining on their sentences? Just to try to get a better picture of the numbers that we're dealing with. So if we could get that information, that'd be helpful.
Co-chair, Representative Lewis will put together something for you.
Thank you.
Yeah, absolutely. Happy to do it.
Yeah.
Thank you, Co-Chair. And to tag along to Rep. Lewis's question, if it's possible to get the figures on what compassionate release is currently looking like and what the opportunities are in that space. I mean,
Yeah, Co-Chair Representative Graber will let you know what the numbers are looking like and also let you know what the qualifications are that someone has to meet for that. Yeah.
Any other questions on the House side, Senate side? Senator? Oh, all right. Well, thank you very much.
Yeah, thank
Good
you.
job.
Appreciate it.
I think we have time at least to begin the next section. Come on up.
Good morning, co-chairs Brogman and Evans, members of the committee. For the record, my name is Larry Bennett, and I'm the Assistant Director of the Correctional Services Division of DOC. Very happy to be here today to share with you some of the innovative and impactful work that we're doing to prepare AICs for success upon release. Before I move on, I would like to tell you a little bit about this photo that you've seen a couple times now in presentations, I think. This is a picture of our UPAC pre-apprenticeship program at Coffee Creek, and Director Reese mentioned the program yesterday. It's made possible through a partnership between DOC and local iron workers, bricklayers, and cement masons, and PGE, who actually funds the program. So we're very excited to have this program. There's a picture of some of our instructors and labor partners at the top there, along with some participating AICs that day, and Representative Courtney Neuron, who is frequently at Coffee Creek for various graduations events. We're always happy to have her. So this is just one example of a potentially transformative opportunity for AICs in custody.
Go ahead.
Very, very briefly, thank you, Co-Chair. I'll just say that I know Representative Graber and I both have had the opportunity to visit with that program and incredibly impressed by the work that is happening there and the win-win opportunities it presents for really everybody involved in it. So I just wanted to give that praise.
Thank you. I appreciate it.
We expect our picture there next time.
I will do what I can. My plan this morning is to provide a brief overview of the division as a whole. I'll talk specifically about some of the programs and services aimed at preparing AICs for success upon release and how those are funded. And I'll provide an overview of the couple of POP packages that benefit the work of our division. And then I'll briefly discuss some of the key partnerships that make this work possible. And I believe I can get through this in 20 minutes, so we'll be back on track. The Correctional Services Division accounts for just over 5% of the agency's budget for a total of $139 million. And these dollars fund approximately 333 FTE and a variety of opportunities aimed at facilitating change in the lives of those that are incarcerated. Correctional Services Division is made up of 10 specialized units, and our work spans the entire length of stay for individuals sentenced to our custody. Some of the work of our division happens behind the scenes, things like records management, coordination of AIC movement throughout the state from institution to institution, and quality assurance work that happens behind the scenes associated with our programs. But much of the work that we do in the Correctional Services Division is direct to AICs. More than 92% of our population will eventually release, and the average sentence is between 4 and 5 years. So the vast majority of those incarcerated within our system today will be back into our communities, and oftentimes a lot sooner than people realize. And that's why this work matters. With the decision to incarcerate those that break our laws comes the responsibility to provide structured opportunities for change whenever possible, and to provide an environment in which that change is possible as well. And we take both of those responsibilities very seriously in DOC. The primary role of the Correctional Services Division is to provide those structured opportunities for change. What you see here are the various categories of work funded specifically by general fund dollars. Those represented in the dark blue section are services provided direct to AICs. And equally as important off to the right in the light blue section there are some of the more indirect services that we provide. We provide opportunities for cognitive and behavioral change, including evidence-based curriculum delivered in partnership with the Pathfinders Network, aimed at recognizing and changing thinking errors. And our correctional rehabilitation team, made up of correctional counselors around the state, works individually with our high and moderate risk AICs to help them better understand the specific areas of risk in their life, to set goals, and to work through behavior change plans. We provide an array of parenting and family-related services as well, including a nationally recognized parenting skills curriculum designed for individuals incarcerated, also delivered in partnership with the Pathfinders Network. And we have a family advocate position at Coffee Creek who works exclusively with pregnant and incarcerated mothers. And that person helps create birthing plans, facilitates caseworker calls, parent-teacher conferences, and delivers strengthened parenting sessions with the clients. And our visiting services team processes an impressive 1,500 visiting applications per month to facilitate ongoing connection for AICs and their families. We provide opportunities for AICs to practice their individual religious and spiritual beliefs. We have 24 different faith groups represented in the population, and roughly 3/4 of adults in custody are engaged in some form of religious or spiritual activities. And it's important to mention that we do this work in partnership with over 500 faith volunteers across the state. In fact, we couldn't do much of what we do without the hundreds of faithful volunteers that give so generously of their time and energy within DOC.
Thank you, Co-Chair. What is the current status of the Family Preservation Project?
Family Preservation Project is currently funded through YWCA, and as far as I know, it's running as it has been.
Okay, great.
Thank you.
Thank you.
Sure.
Press.
Education and work-based training has probably been one of the fastest growing segments of services that we offer to our AICs over the last couple of years. General fund dollars specifically provides for adult basic skills development, such as adult basic ed, English as a second language, and GED, as well as vocational programs like cosmetology, para-optometrics, and welding. And I'll talk more specifically about college education here in a couple of slides. As AICs enter the 6 months, the final 6 months of their sentence, we provide a variety of transition and release services, including a transition preparation curriculum, which covers topics like interview skills, building a budget, tenant rights, and how to work successfully with your parole and probation officer. And in the final months, a release counselor is assigned to work with the individual releasing collaboratively, along with the County Community Corrections Agency, Board of Parole, to put together a release plan that addresses housing options, transportation arrangements, reporting instructions, and conditions of supervision. Also essential to successful reentry are the transition fund dollars provided in our 23-25 and in the 25-27 GRB. We're able to use these funds on a case-by-case basis to address, eliminate needs for those that are releasing with less resources. So we can pay for DMV fees associated with obtaining an ID, release transportation, basic hygiene and food items for those that are releasing across the state, and warm clothes for those that are releasing in inclement weather. It's worth noting that the funded programs within DOC are evidence-based and designed specifically for justice-involved adults. And our correctional case management team continually researches evidence-based practices, evaluates program outcomes, and ensures program fidelity through ongoing staff training and observation. And finally, we provide a variety of indirect services, some of which are listed here, including sentence computation and expungement processing. We process expungements for all Oregonians, whether they were sentenced to incarceration or they were sentenced to community supervision. And we operate legal libraries within each one of our institutions as well to ensure access to the courts. And we oversee and coordinate volunteer services and victim services for the agency. Central to our work with victim services is our victim notification system, which provides automated alerts to registrants, including crime victims and survivors, anytime a person in custody throughout the state, whether they're housed in a county jail, they're housed in a DOC custody, or they're housed in OIA. It's a sum total of some 23,000 beds. Any movement between those beds or releases triggers a notification to people who have registered for Visor. Some of you will remember that we made a significant change in 2023 in vendors, and we couldn't be more pleased with the system today. The system that we operate is known as the Victim Information System in Oregon, or Visor.
And
The new system, yes, sir.
That's tied into everything as well as Vines was? So counties, police,
Absolutely.
victim programs, wherever?
Absolutely. I would say it's better tied in than Vine was.
Okay.
The new system enables us to provide substantially more modern, user-friendly, timely, and efficient solutions for end users, and at a significantly reduced cost, about 50% cheaper. And all associated data is solely possessed by the state of Oregon. So there's no third party is involved to own the data, with the potential of that data being sold at some point. The platform is also entirely within the state's control and able to be expanded as needed for other purposes. As an example, medical benefits start and stop when individuals come and go from the correctional system. And we're currently working with OHA, who is interested in using the notification to trigger automatic stopping and starting of benefits when someone enters the correctional system or releases from the correctional system.
So a question then.
Yes.
When we first came in 2015, 2016, we actually had a task force on incarcerated veterans to figure out the most effective way to find out who veterans were, because at the time, there was an Attorney General opinion that said the department couldn't automatically transfer information that you had to ask. I've been trying to get 2 Attorney Generals now to change that. They can't find it anywhere. Do you have that rule or
Authority to do that?
I'm saying, do you have that rule or opinion anywhere so we can get it changed?
In terms of communicating with any partners or sharing that information, the information that we can with, of course, DOJ consultation in terms of what what and how we can share information, we're more than happy to have that conversation. Did I miss your question?
You missed my
Okay,
point.
go ahead.
Right now, veterans coming in, there's certain services they can still collect while they're in, but there's certain services they can't.
Okay.
If we rely only on who says they are versus who may think that they are or want to be, it's not always the same data. We found that out the hard way. There was, at the point, we simply wanted at one point, when you're during intake, vet or not vet, and run the program, get to Social Security and find out. We were told we couldn't do that. I'm trying to track down why we can't do that.
These.
Larry, I got the answer.
Yeah, great.
Co-Chair Evans, what I have found is it is not in writing. I've spent a lot of time over the last few months trying to hunt that down with my team. And it was a verbal conversation and verbal advice, apparently, and not through written form.
So as of tomorrow, theoretically, you could take their Social Security numbers when they come in and see if they're veterans. There's nothing prohibiting you.
We could. The advice that we're getting verbally from DOJ, and I talked to DOJ as well, is that we shouldn't be doing that. So I'd have to have more conversations around that. My understanding, though, also in talking to my team as I was trying to dig up this information, was that that because we have those two VA staff now coming in and working with our population, that hasn't been a problem because they get the information directly from the AIC themselves.
Okay, but it's on a verbal from an Attorney General in the past, and the new Attorney General saying the same thing?
I'd have to talk to, no, it's, I'm sorry, it's our legal counsel.
Okay, it's an offline thing?
Yeah. Yeah,
I want that settled.
okay, we'll
Thank
follow
you.
up. Yep.
Thank you.
Rick?
Thank you, Co-Chair. So this is the same system that County Community Corrections is on or going on? Is that
Co-Chair Evans, Rep. Lewis, yes, all county jails.
Okay,
OAA.
so are the counties having to pay for anything in connection with connecting to the new system?
Not to my knowledge. DOC has taken on those costs to make that transition. And so it's actually funded. The VISOR program is funded through inmate welfare fund dollars. So whenever AICs earn points with their positions in the institution, that a portion of those points is pulled to pay for victim services, and this is one of the things that it covers.
Okay, one more question. Thank you. So are all county community corrections online now? with
Correct.
this? Okay,
That's correct.
thank you.
You have a question? Good, go ahead.
Okay. And we currently have almost 150,000 active registrants, and in 2024, almost 400,000 automated notifications went out. I mentioned that education's been one of the fastest growing program areas over the last couple of years. There's two primary drivers for that. One, it was the reinstatement of the federal Pell Grant for adults in custody. And the second was the passing of Senate Bill 1522, which required DOC to establish and pilot online education at two of our institutions, Snake River and Coffee Creek. I am pleased to say that as a result of these two changes, the number of AICs participating in college courses grew from just 98 in 2022 to over 800 today. And it's our hope that at some point online education will become available in the 10 remaining institutions as well. This is Miss Michelle Ellers, pictured here. I believe she may be giving public testimony on Thursday. She was able to graduate with her bachelor's degree through Portland State University at Coffee Creek and released just 30 days later. Go ahead, change slides. These are a couple of policy option packages included in the GRB that directly impact the work of our division. The first is improving housing outcomes and reentry, which is part of the governor's larger effort to reduce homelessness. And DOC's portion focuses on addressing barriers to stable housing prior to release. Formerly incarcerated people in the United States are almost 10 times as likely to experience homelessness, and with each subsequent incarceration cycle, that number climbs and climbs. So addressing these housing barriers and ultimately securing stable housing prior to release, we believe should directly impact recidivism rates for the population. And the Gender Responsive and Trauma-Informed Care POP is a much larger POP package associated with the work going on at Coffee Creek. And this particular POP would provide for increased resources for us to meet the needs of the women in custody. Yeah.
Senator?
Thank you, Co-Chair. I'm curious to know what the caseload numbers are right now that the housing coordinators are carrying.
We don't have housing coordinators currently. The housing decisions at this point are made solely by community corrections upon release. And so what we are proposing in this package is that we would be able to do some of that front end work before the person releases and identify housing, partner with the counties.
Thank you.
Any others? Go ahead.
Okay, in addition to the general fund programs and services that we're able to provide, there are a number of opportunities that result from grants and really incredibly generous donors. Not unlike the general fund programs and services, those involve significant collaboration with other state agencies and external partners to ensure we get the most out of these opportunities. One of the best examples of a significant collaboration is our Corbin University program at OSCI. That program enables adults in custody to earn a Bachelor of Science degree in Psychology, Social Services, and Leadership, and it's completely paid for by generous donations to a nonprofit organization known as Paid in Full. Every year, 20 to 25 AICs enter that program at OSCI, and this past summer, we had our first cohort of 18 AICs graduate. It was a beautiful day, and quite frankly, with all the fanfare of any college graduation that I've ever attended. So it was a pretty cool event to be a part of. Director Reese mentioned our Braille transcription and production program at OSP and soon to be at Coffee Creek. Braille transcriptionists are in short supply across the United States, and there are a couple of other states that run Braille transcription and production programs in prisons, and they've been very successful programs. So we've partnered with Oregon Corrections Enterprises to establish those two programs, and we anticipate, as Director Reese mentioned, that they will be self-sufficient as they take on contract work. Our Big Machines, Big Opportunities program is pictured here as a heavy equipment operator program that results in industry-recognized certifications. According to the U.S. Bureau of Labor, employment in the construction industries is projected to outpace all other occupations through 2033. Over 600,000 job openings are projected annually, and the median income for construction equipment operators is about $60,000 a year. So this program is made possible through a partnership between DOC, ODOT, and Baker Technical Institute. And the picture you see here is of a land lab, which is the third phase in the program. What begins in the classroom transitions to simulator work and then actual hours on the machines. And this is a land lab happening at Warner Creek Correctional Facility. Our Parenting Inside Out 2 and African American Fatherhood program build upon primary parenting skills curriculum we already provide by providing culturally specific parenting curriculum and real-time coaching for AICs who are interacting with their own children during visits. And we're able to do this in a partnership with DHS, the Pathfinders Network, and Self-Enhancement, Inc. An OHA grant enables us to fund reentry benefit coordinators who work with eligible releasing AICs to complete the Oregon Health Plan and SNAP applications before they release so that those access to those benefits are more readily available. And a BJA grant made it possible for us to partner with Portland Community College's Legal Resource Center to provide PCC Clear clinics, which enable AICs to receive assistance in clearing up aspects of their record that can make it difficult to get a job and to get housing. And finally, our workforce centers. Okay. This is one of the most exciting partnerships.
We're going to stop there because it looks like you're getting in the meat of some other things, which is good.
Okay.
We've got about 2 minutes till the committee's over, and I want to make sure that we come back tomorrow and can pay attention to that. So thank you very much. See you same bad time, bad station. Okay. We're going to close the informational hearing for today. Things we need to know for tomorrow.
We'll be back with you tomorrow.
Be back tomorrow. Thank you for your patience today with all the questions. Anything for the good of the order? Okay, we're adjourned.